Good morning. My name is Edward Czerwiński. I am a Professor Emeritus of the Jagiellonian University and Senior Medical Director in FutureMeds. I wish to discuss with you problems which we have with long treatment of osteoporosis. Long, I mean 10, 20 years or more. So how long should we treat osteoporosis? I will talk about the longest clinical trials which show us the safety in long treatment, then the current standards, criteria for efficacy of treatment, and brand new issue, drug holidays, advantages and disadvantages. Osteoporosis lasted whole our life for doctor since the diagnosis, and even in Poland we have every age span of 82, so it means that we'll treat that woman 24 years. The Queen II broken her released in 1994. That means she could be treated even for 28 years. And it is a different condition of lady when she is and there is a different condition of women when she is 56 and different stage when she is 96. Therefore, how long we treat pharmacologically seems to be answer is very easy. That means as long as benefits of the treatment overweight, there is a complication. But when this is not so simple to answer. We have a couple of long-term clinical trials. I mean, alendronate 10 years, risedronate 7 years, zoredronate 9 years, and the best documentation, denosumab, 10 years. And we know that under the treatment of alendronate, we have increase of BMD of the spine, as well an increase of the BMD of the hip. However, after 5 years is not so high, and have well documented a very rapid increase of BMD under denosumab treatment, of course higher than alendronate, both in lumbar spine and in total hip. We have also data that the anti-fracture efficacy persists over 10 years, as here is the virtual placebo, and we still see that there is the effect similar as it was under the active treatment, in placebo. So what we learn from standards, I just read the IOF standard, NOF, ASBR, UK, PL recommendations, and they are almost equal. The differences are in details, and we know that we have evaluated the therapy, oral bisphosphonates after 5 years, IVs after 3 years, and denosumab after 5 years. And what's the next? I divided the scenario in two. The right is a positive one, have the good result of our treatment, and the worst one having achieved a good BMD or fracture occurred. So after 5 years, we continue both, but here we can apply a drug holiday. After the next 5 years, here when we have still low BMD or fracture, we either continue or change the medication because just that one may be not effective. And the same, not the same, but we continue, but we have holidays, and after holidays we turn. And so on for 15 years and even longer. All of us, we have patients even over 20 years. And unfortunately, even quite new standards of the National Osteoporosis Guidelines Group in UK, it says that after 10 years, decision of the next treatment should be on the individual basis, careful consultation, and specialist advice to be sought. That means that we have no guidelines, and we have to base on our knowledge and even more on our experience. We have a concept of target to treat, and the basis for that is that if we achieve a T-score higher than -2, the effect of non-vertebral fracture is not so quick and even flattened. And but here we have the T-score, and here we have the incidence of the vertebral fractures 1 year. So the whole group of adenosine in age groups of adenosine, even if the prevalent fracture. So here we have the slope, and here it's been flattened. So it says that if we will not achieve more, perhaps if we will treat over -1 and 5, therefore we can stop. Just the next year we have the newest goal-directed osteoporosis treatment as ASBM group for position statement, and is goal-directed strategy, long-term management treated patients with therapy of anti-resorptive alendronate, isendronate, sonendronate, denosumab, and bone-forming agent, teriparatide, abaloparatide, and romosozumab. It says that we can decide that we achieve the goal where they have no new fracture. However, asking patient when she had a fracture and she said no, that means she have no clinical fracture, but she may not know that he have broken vertebra. Therefore, we need imaging of vertebra. And then BMD, which is the strongest indicator of the treatment efficacy and have a very strong relationship between increase BMD and decrease of the fracture risk. Therefore, they stated that the minimum was -2.5, but if someone is still on the high risk, or we foresee the drug holidays, so we rather should hit to 1.5 T-score. When we achieve goal of the treatment, I mean no fracture and good enough BMD, say neck -1.5 or 2, we should consider a drug holiday, because this will significantly decrease the risk of complications. There are two of them, the major one being the atypical humeral fracture and medically induced osteonecrosis of the jaw, what is one of the most difficult diseases. So what we are afraid of, first the typical humeral fracture, and in the clinical settings, clinical trial settings, in freedom we have 5 only, I mean 0.2%. no in the bone-forming agent, in romosozumab. In bisphosphonate use, we have in the Danish study have 3,000, and after 5 years, 7,000. So no much. Unfortunately, medication-related osteonecrosis of jaw is a nightmare of our dentist. In freedom, over 10 years, we have 35 cases, that means 1.45, and non-interparotid balaparotid, 1, and frame romosozumab group. In placebo is 0, but it could be 200 bisphosphonates up to 500, but there is a study that in patient over 55 there was 3.4 cases. Denosumab, the report even 2.8%, and in publication from the dentistry field, we will find that in group of osteoporosis there is 2.3%, in malignancies even 5%, and we know that drug holidays reduces definitely MRO&J risk. So if we decide for drug holidays, in case of bisphosphonates, it's pretty easy because their half-life and bones are years. So for alendronate, even 5 years, we watch only 3% over 5 years, and one just ongoing treatment. Zoledronate the same, and zoledronate even longer. The brand different story is with denosumab, because after the session of denosumab, we have a rapid drop of BMD in the spine to 0. I mean, the previous standard measure, and in the femoral neck even longer. That was BMD. Fracture risk. In the huge study of Kaiser Permanent, there was no increase, and however, some publication proved that it could be increase of the fracture risk. And denosumab is still different story with a dramatic increase of the fractures of spine. I mean, as remains, come back to the starting point, and there is a risk of multiple vertebral fracture in those who already had broken spine. So if we came to the decision whether to have a drug holiday or not, we have weighed patient benefit and risk. From the one side, we have depression of risk of MRO&J and IFF, but on the other side, you have risk of the new fracture, and denosumab even increase of the fracture. It is very difficult decision because we have many variabilities. The patient age, the prevalent fracture, health status, determined quite often by genes, diabetes, steroid, malignancies, smoking, and of course, different medication. The more potential medication, the higher the risk of complication, and of course, the duration of treatment. Now, summing up, first of all, we treat osteoporosis as long as it is. However, we can think about the break in the treatment, and we have in pharmacological management. The answer is easy, with it as long as the benefit outweighed of the risk complication. But when it is, it's not so easy to decide. The goal, the treatment is the prevent of the fracture. A BMD is the one of the indicator of the success. Treat to the target determines the efficacy or lack of the fracture, but including exclusion of the vertebral fracture on imaging, and increase BMD up even higher than 2.5, and special cases even higher than 1.5. Drug holidays are recommended after treatment goal is achieved. Interruption of bisphosphonate is easy because they are stored in the bone for a long time, but after discontinuation, the nosumab, we have a rapid decrease of the BMD, but we can prevent that with some methods. Drug holidays definitely reduces the risk of major complications, jaw necrosis, and atypical femoral fracture. Atypical femoral fracture is the result of hypermineralization caused by too long anti-disruptive therapy, and with some caution, we can avoid that. It is not the case for ONJ because many variabilities, and the risk is as highest in the nosumab, zolpidem, and then oral BPs. Have to remember that for denosumab, it can occur even after 1 year. I had such a history. The risk of complication notably increases after 5 years of treatment, and after 10 years, you have to discuss with patient details, the risk and the benefits, and make up decision with the patient. However, on the very end of discussion, patient says, doctor, I trust you, and what do you advise me? So we have to do it in a patient benefit. Saying that, thank you for your attention, and I hope you like it. Bye-bye.